So good morning, everyone. Thank you for coming to our doubleheader. It's my pleasure to introduce Don Goldmann from IHI. Don is involved, as some of you know, in terms of advising on our ACGME grant. But more importantly, Don is one of the pioneers in improvement science. He's been at IHI for a lot of years and recently moved into a new role as Chief Scientific Officer, Emeritus, and Senior Fellow, and he may have some more to say about that. I should mention that Don, by training, is internal medicine. We won't hold it against him, but he actually does hold a position in pediatrics as an infectious disease specialist as well. So, Don, thank you for coming. And I should also mention, Don was supposed to be here in March with our fake snowstorm, and he was kind enough to reschedule and come today. So we appreciate his ability to be flexible about that as well.
Great. Thank you. So I have a problem where I get on telling stories as I speak, and that means I never get to the end, but it's okay because it's just more stories. I'll warn you, there is some relatively technical stuff. So when we get to the technical stuff, pay attention because it's going to be a change of pace from the stories. So with that background, what did I just do? There we go. So I'm going to talk about how to perform academically credible, scientific quality improvement without large grants, so that may be a surprise to some of you, leveraging interprofessional knowledge and skills and teamwork, and integrating the quality improvement work with routine work at the bedside. So that all sounds like a challenge, but it's meant to make improvement science really accessible and practical. And the reason I put all of my titles on the slide and I left off the Harvard T.H. Chan School of Public Health professorship, but I put them all there not to look important, but because it just shows that if you do rigorous work in improvement science, you can get promoted even at a place like Harvard, because this kind of work is increasingly appreciated. The trouble is that a lot of what you see in quality improvement is not rigorous nor scientific, and therefore the results aren't credible. And if you perform that kind of work, you don't get promoted. But if you're interested in academic pathways, I know some of you probably would be, there is light at the end of the tunnel, I promise you. So I gave a talk at a conference called Cool Topics in Neonatology in California. It's a California NICU folks a little while ago, and I thought it'd be kind of cool to talk about when QI can be so not cool, because I know you all, or at least some of you, maybe you're the converted, but a lot of people in academia harbor a lot of doubts about quality improvement. So first and foremost, it's not cool when improvement sciences aren't humble. And we tend to talk about the wondrous achievements of quality improvement. Let's say inflammatory bowel disease. There's all kinds of great work coming out of Cincinnati Children's. But we really should be honest that technology and therapeutics have made a lot of this possible. So since I was in training, there have been dramatic improvements in survival of tiny babies, and I guarantee that much of that improvement occurred before the neonatologists at Boston Children's Hospital knew anything about quality improvement. It was due to Mary Ellen Avery and surfactant and other advances in therapeutics. A lot of diseases that used to fill our wards are now gone, and probably many of you have never seen a case of Haemophilus influenzae meningitis. And within 1 year, we're able to develop and deploy a vaccine for Ebola. That's pretty amazing. Drugs have turned HIV into chronic disease for many people. And I never thought in my lifetime I'd see a 12-week cure, albeit for $90,000 for hepatitis C, which is truly amazing. And I've listed some other areas as well. And this is what's made it possible to demonstrate the quality improvement as of added value. I guarantee you the idea of zero central line-associated bloodstream infections or CLABSIs 20 years ago would have been absolutely impossible, because we used hard as nails polyethylene catheters that traumatize the vein and cause thrombosis, and the same is true for ventilator pneumonia. So let's be respectful to what makes our work possible. A lot of clinicians feel that the QI isn't cool, and I've put some of the reasons here, tend to associate it with old-style quality assurance or pay-for-performance. And try as we might, that's the reality. Those of you who are physicians know, I'm sure, a lot about MRSA and value-based payment systems. That is benchmarking and paying for performance. And that is old style, in a way, punitive or incentivized quality. QI gurus tend to keep talking about the industrial origins of QI, Toyota production systems. It came from some place in the East. It's religious. We have a lot of jargon, and the extent to which we use that jargon is the extent to which we undermine our credibility, I think, for clinical people. We tend to focus on non-clinical processes and outcomes. So I'm sure none of you in the audience do this, but if I'm talking to a group of urologists or surgeons about quality improvement, I talk about waiting times and lean and all that kind of stuff. They glaze over. What they care about, if they do prostatectomies for cancer, they want to know, will the man be able to have sex, will he leak urine, and will the cancer be extirpated? And if you don't relate to those clinical goals, then you're kind of irrelevant. We tend to want to do it by the book, and I'm telling you, if you want to do a process flow diagram with a bunch of surgeons, you don't do it at noon in a conference room when they're in the OR. You go to the OR at 5:30 or 6 in the morning and you sit there and have the same crappy, coffee and donuts or bagels they have, and you get them to tell you about their work. We're not really upfront about the fiscal agenda. We always say, well, QI is free. It'll pay us back if we really do it well. It'll pay you back someday, but the resources involved, the opportunity costs, your time, the staff's time are really quite major. And then I put 3 things in green because I think they're most important. We don't provide teams with the data they need to improve. We've talked to some of the leading institutions in the country when they're trying to teach residents how to do QI, and you're part of this ACGME work, which is terrific, but I guarantee you the data that the residents need to do what matters to them in terms of improvement is not a click away. Not in any hospital I've ever been in. In the very best hospital, it was 3 clicks away for data that was sort of relevant to what the residents were doing. So until we have real-time data that literally is available when you need it, we're going to be held back. We don't emphasize the academic potential, which is why I'm talking to you today, and we often don't produce credible evidence of effectiveness, which I've already mentioned. And those are really key in getting traction and sustaining the momentum of quality improvement. It's not really cool to confuse your peers. So this is improvement science. That's what I'm talking about today. But there's healthcare delivery science that was coined by Jim Kim at Dartmouth and promulgated widely. There's implementation science, which is the jargon of the federal government. You cannot put in a grant that has anything to do with quality improvement to NIH. It's under the dissemination and implementation science portfolio of work. There's system strengthening, there's systems engineering, and then there's a bunch of methodologies that I'm sure you're familiar with. What we teach at IHI, the model for improvement, Lean Six Sigma, Lean Six Sigma, all of these have the same roots, yes, in industry, and they're all basically the same thing. They're fine-tuned for different purposes. Lean's really good for taking out waste. The model for improvement is really good for testing at the bedside, but they're all fundamentally the same. So there's nothing worse than a field can do than to balkanize its own members into various camps so that they can all have their own journal, get promoted, have their own society, have their own international meeting, and puff themselves up as being the #1 implementation scientist in Missouri. So you see what I think about that. Now, how do you make translational researchers? How many of you do translational research that's more on the bench to bedside? Anybody here does that? Just a few of you. Well, you got to make your buddies who actually do this work comfortable, and at Boston Children's, there are a lot of those folks. And basically, what I tell people is it's the experimental method with a little bit more systems thinking and behavioral science. And for 10 years, maybe longer than that, I worked with a PhD scientist at the Channing Laboratory in Boston trying to develop a vaccine for Staphylococcus, MRSA to be specific, we were targeting at that time. And you may think that that's not quality improvement, but it's basically the same fundamental principles. We had a theory that this substance called PNAG, extracted from the cell wall of a staphylococcus, could, if injected into animals and then man, produce antibodies that would be opsonic. That simply is from the Greek, prepare to eat. It makes it possible for white blood cells to gobble up the staphylococci, and that was our theory. So we predicted that if we injected this purified stuff into an animal, these were rodents, that they would produce antibodies, and in fact, those antibodies would be opsonic. We did a long series of hundreds of PDSA, Plan Do Study Act cycles, in those rodents to determine which route do we inoculate this PNAG. Sub-Q, IM, does it have to be IV? What's the dose? Do we need an adjuvant like alum to add to it to get the antibodies? And then once we did get the antibodies, would they in fact in a test tube be opsonic? And oh, then by the way, when we did all that, we needed an animal model of infection. Probably 60 or 70 PDSA cycles, prediction, testing, analyzing results, trying again if it didn't work, to get an animal model of infection that would show whether or not we could protect these animals against staphylococcal disease. So that's basically all there is to quality improvement in my view. It's basically the experimental method. Now you're saying, well, there's no, we work in complex environments, the ward, the patients, the teams, it's all much more complex. Well, you know, animals are complex too. If you feed them a different chow, if the temperature of the animal room changes, if the animal handler handles them roughly, if they come from a different supplier, all of that affects the results of your experiments. But that's not the same, right? What about the culture? Well, the culture in the laboratory matters too. This particular scientist, who's a dear friend and very effective guy, tells what I regard as offensive sexist jokes. And in the laboratory, most of the doctoral students and postdocs happen to be women. And I can tell you that doesn't go over well. If you want a culture of psychological safety in which those people would challenge the senior PhD scientist on the grant that's supporting them, if you think that's a good idea, well, go do it. But for me, I was the guy that had to say, I was there mainly to call it out. And to say, you know, I don't think that theory is really holding up because there was a kind of chill in the room. So the other thing that I learned in the lab, and this was brought up to me by a neonatologist, Timmy Ho, he said, I don't understand this quality improvement stuff. How come you don't keep a lab book? In the laboratory, we kept a lab, a record of every PDSA cycle we did on every animal. Because we knew that somebody might come in someday and want to replicate what we did or challenge what we did. I don't know of any quality improvement program that can go out and say that the people doing quality improvement in my organization are keeping a lab book in a bound notebook so anybody can see what they did. Now, I know that's time-consuming and people are on grants and you're not, but the basic principle is there. Keeping a record of what your predictions were and what you found is very important. It's not cool to claim that other sciences are what the founders of quality improvement described years ago, Deming, Duran, and Shewart. Those names may or may not be familiar with. But trust me, they did not have the scientific sophistication of methodologies that have developed since those pioneers. Behavioral economics, qualitative methods in ethnography and medical anthropology, network sciences and analytics, big data analytics and machine learning, and most of all, I don't think that they fully appreciate it, nor do they use today the principles of epidemiology. So I'm an epidemiologist. That's what I did at the Centers for Disease Control and Prevention. I worked up epidemics of dysentery on Colorado River raft trips, and so I respect the power of epidemiology. And so one day, Lloyd Provost, who's a wonderful senior improvement scientist who works with IHI, asked a room full of people about half this size, how many of you have ever written a paper or done an experiment in quality improvement where you found special cause? Well, special cause just means that there's a statistically important change, either better or worse, that can't be explained by random chance. And almost nobody put up their hand, but I did. I said, well, I've actually written 20 papers on special cause. I call them epidemics. And so this failure to crosstalk is a big problem. And I went back to Sir Austin Bradford Hill. If you're ever involved in litigation or a court of law over some case, God forbid, I can tell you how unpleasant that is. I actually relish the opportunity to do expert witnessing because somebody has to do it, and I'm a sound epidemiologist, and I think I can be helpful. Austin Bradford Hill, back in the 60s, described these key features that lead you to move from association to causality, from something that looks like it's related to something where you can say, well, that could actually be causal. And in quality improvement, we really want to know whether what we're doing caused the effect that we say it caused, that there's an attributable effect to our improvement activities. And I find these to be pretty useful, and I'm not going to spend a lot of time on them, but first of all, plausibility. Does the thing make sense? If I tell you that sleeping on a hard bed is going to cause brain cancer, you probably got to do a lot of testing, and you'll call out very strong statistical associations. You'll want to see a lot of evidence because that just doesn't make sense. If I tell you that sitting in this room, listening to me talk will change how you practice medicine or how you treat patients in the future, I know based on a lot of evidence that that's baloney, a very low degree of plausibility on just a single educational exposure. So much of what we do doesn't really sound plausible. And if somebody crinkles their eyebrows about what you say, you ought to go back and say, well, you know, if I'm going to try that, I ought to have pretty good, robust evidence that works. So biological plausibility in science, or just plain old plausibility in quality. How large is the effect? You know, there are endless studies that have p-values that are very, very tiny, showing that an association exists. For example, I once did a study on nettlemycin versus gentamicin and nephrotoxicity, and the p-value for nettlemycin's superiority was 0.00001. But the difference in creatinine was not even a fraction of a creatinine unit because we had thousands of patients. And so the biological importance of that was really pretty trivial. So Bradford Hill wanted to know, is this a effect you can see from the back of the room? This is a bit of a detour, but do any of you know what the standard for a relative risk is, or how big the magnitude of effect has to be in a court of law in the United States for, let's say, whether silicone causes SLE? What do you think the judges regard as a important impact? None of you have ever, these are called the Daubert criteria, relative risk 2.0. So if the risk isn't twofold, it's not considered important. Now, I think that's not a very sound thing. If, in fact, breast implants are associated with autoimmune disease with a relative risk of 1.10, that's still thousands and thousands of women who are at risk for these diseases. So I don't support that in the court of law, but the magnitude of the risk does matter. Consistency, has it been seen in multiple settings and circumstances? So if you find here, I know Mary here in the front row is very much an expert on the use of simulation. It would be great if she were to replicate here, which she's doing, what happened in Cincinnati where she came from, I think. That would show the same kind of effect under different circumstances and context. Temporality is absolutely the key. Very often I'll read a paper where, believe it or not, when the intervention occurred in relationship to the claimed effect is not clear. And in some papers, it even looks like it occurred in the course of the effect. So temporality is absolutely key in quality improvement. Biologic gradient, that sounds kind of irrelevant. This is all about dose, but I've already hinted at that. I am giving you a very weak dose of quality improvement today. If I expect this to have an effect, you will have to invite me back at your peril, probably every month for the next year, or you can tune into video lessons, or you can take the IHI HarvardX massive open online course on quality improvement. That begins to build up a pedagogical dose that may actually have an effect. And in quality improvement, we often don't think about what is the dose we're giving and has it been received. We'll not spend too much time on coherence. It just means, is there available evidence that supports it? Was the experimental method used? I've already talked about that. That's the PDSA cycle. Analogy, is it similar to other interventions? Can we extrapolate from what other people have done? And then specificity is, does the exposure lead only to the outcome? That's kind of type 2 error specificity, which you're probably familiar with. Could something else explain what happened other than what I did? And in most quality improvement work, we don't have a very good what would have happened if we had done nothing. That's the secular trend. It's what happens over time, irregardless of what you did. It's called counterfactual in health services research, and we very often do not have an adequate comparator group to show that what we did was uniquely responsible for the outcome. In quality improvement, there are a number of things we do that are similar to what Austin Bradford Hill described. Statistical process control charts are ideally suited to show temporality, that the effect occurred after the intervention. Plausibility, I'm going to spend some time on when I show you a driver diagram. We have many ways to display our degree of belief or our confidence that what we're suggesting as a quality improvement intervention actually makes some sense. We're very strong on experiment with PDSA cycles. We do talk about the dose delivered. I'll get to that in a minute when I bore you with logic models. We are very keen on consistency, on showing that we can have the same effect in a different ward, a different service, a different hospital. And analogy we use all the time. So you're all familiar with the Michigan Keystone work showing a major reduction in central line-associated infections by Peter Pronovost and colleagues. The analogy would be if you do that in England, which they tried to do in a matching Michigan project, that it should work because it's a collaborative also. But in fact, in this case, the analogy was flawed because they didn't really replicate the kind of collaborative that had been done in Michigan. They tried to do a cheap version of that, and it didn't work. But we do try and use analogy. Now, I'm going to talk about improvement science, and you can time me if somebody has a watch, because I don't have a lot of time with you today. It's going to take me 5 to 7 minutes to tell you everything you know about need to know about improvement science. So those of you who are hired by the hospital to do this, you know, this is it. You can just go home and we can all have a nice summer day. No, it's a joke, but I think you do need an elevator speech. You do need to be able to tell people what it is you do in 5 to 7 minutes. So people tend to talk about Edwards Deming, the great founder of the field, and the system for profound knowledge. So if I go up you know, I don't know you, but if I go up to you and I say, I can tell you about profound knowledge, you're going to say, they don't have it. Yeah. They're all in. You just love the idea of profound knowledge. So I just wasted 30 seconds going over that. But there are only 4 parts to profound knowledge. First, a theory of knowledge. So the fancy word for that's epistemology. I spent a week at a fancy, what was the name of the place? Cliveden House outside of London, where Profumo had an affair and it cost him the prime minister's role because it was a very salacious thing. Epistemology just means how do we know? I had to look it up. I had to Google it while I was there. And how do we know is we do testing. We learn through testing. That's epistemology. Appreciation of a system. If you can't describe a system, if you don't really understand what the work is, the flow of the work, how do you possibly know where to intervene, where the failure modes are, where the points are that you can actually improve performance? So that's the appreciation of the system. Understanding variation has 2 components. Variation over time. Does the change I'm seeing, in fact, meet some sort of statistical threshold for not being random chance alone, that it's really different, I've really improved something? And variation amongst wards, doctors, hospitals, countries. That kind of variation we call heterogeneity, and you can learn from the good performers, but you can also learn from those that haven't succeeded. And very often I hear my colleagues at IHI, bright spot, all it's about the bright spots. Well, there are dark spots, and we need to learn from where people have tried just as hard and have failed to the same extent that others have succeeded. What happened there that we need to guard against? So And the final is psychology, just behavioral science. How do I persuade you to change? And hopefully I know enough about behavior that I can use effective levers to help you change. And this all boils down to something you may have seen, which is utterly and overly simplistic, but this is the model for improvement described in a book by Langley and others some years ago, and there's a new edition of that, but it's really, really simple. What are we trying to accomplish? How much by when? What is our measurable aim? Boston Children's Hospital's thing is till every child is well. Well, what the heck does that mean? Do we really mean well? What do we mean by well? What is the case definition of well for people flying in from Saudi Arabia with or a bone marrow transplant? What does it mean to be well? Or somebody born with very severe congenital anomalies? I don't know what it means. I don't know by when that's going to happen, and I don't know how to measure it. So you need a measurable aim. How much, by when, for whom? And then how we know that it changes an improvement. What are we going to do that will actually show that we change things? And that's a measurement framework for the work. And then you do your PDSA cycles. What can we test? What can we try? And Don Berwick, when I really challenge him on this, he always says, go and do something by Tuesday. What can I do by Tuesday? Well, actually, I don't think that's a good idea. Changes should be on a causal pathway that you believe, if you make these changes, will result in a better outcome. You don't just go test by Tuesday because you feel pressured to do so. It has to be a test along a ramp or pathway that you believe will produce change. So that's it. That's the model for improvement. So in summary, here's the elevator speech. Specify a clear, measurable aim and state when you hope to achieve it, how much, by when, and for whom. Understand the system in which you're trying to reach the goal. Where can it fail? Where is there inefficiency and waste? Where can you improve it and then monitor to make sure that it stays improved? Can you be explicit about the expected or predicted impact of changes you are testing on the outcomes you want to achieve? And I'll show you a driver diagram and logic model that displays that in a minute. This is really specific. So if you're going to do something in the quality improvement, let's say you're going to take razors out of the operating room, right, if you're an adult surgeon. Well, probably they've all done that by now, but the attributable effect of taking out razors on surgical site infection is probably about 1.5 to 2%. So if you bet the farm on taking razors out to reduce surgical site infections, you tell the CEO and CFO that's your thing for the year, and you don't reduce surgical site infections, it's because you didn't explicitly state the attributable effect, the predicted actual effect of that change on the outcome of interest. So just keep that in mind. Be clear about your implementation plan and the outputs of every activity you plan. Very often people will go off and do 100 activities and they don't have a clear idea or prediction of what that implementation strategy will have on the outputs they want, the knowledge gained, for example. Learn continuously from testing or experiments. Use data to track improvement over time. Use the principles of variation I just outlined. And understand how to change human behavior. And that's it. How long did that take? Anybody time me? 5:54. Thank you, Mary. So, and that's it. That's all there is to it. Well, I do want to emphasize why understanding systems is so important. Anybody here from the Midwest? Anybody know Schwan ice cream? Yeah, good. So Schwan Ice Cream, terrific Minnesota family business, in 1994 had an estimated 224,000 cases of salmonella due to tainted ice cream, and it almost put them out of business. You see the cute little trucks that you can get that on eBay. It's kind of expensive, it's sort of an antique now. There's their logo modernized. Almost put them out of business. The system for making ice cream, which I'm sure if we had more time you could all recite to me, is really very simple. You have chickens, they lay eggs, you take a bunch of eggs, you crack them, you put them in a big vat, you take them to the ice cream factory, they pasteurize the mixture with whatever they do in their recipe, and then at Schwan, they put them back, the pasteurized product back in the truck, and they take it to a place where the flavorings are added, they're put in the cartons, and they're shipped all over the United States. That's the system. The failure mode in that system, the problem was that somebody wasn't monitoring what happened to the trucks. And so the trucks that were used to ship the unpasteurized eggs to the plant to be pasteurized were then turned around without proper sanitation and took the now pasteurized product back and contaminated it with a salmonella that's found in many, many chickens and eggs in the United States, and you had an epidemic. So systems matter. Here's why it matters to me. I'm a gardener. I do all my teaching from my garden. I'll show you a video you can look at later. But this is my squash plant last year, and if you look closely, you'll see some foil underneath the stem of that plant. That's to protect against the squash vine borer. These flies apparently lay eggs. They burrow into the squash, and they kill the squash. If I don't have a system that tells me when to go out, and I did this last night at 8 p.m., having come back from vacation, I put foil around these plants because I have a system for doing that. It turns out that when I looked this up in prep for a recent talk, that isn't really very effective. You have to cover the entire stem as it continues to grow. I didn't know that. I've been lucky so far, but that's my system. And let me talk now about driver diagrams and logic models. This is the technical part, but I'll illustrate it with stories because that's how you determine what your causal pathway looks like, your prediction that you will be able to reach the outcomes you want to achieve. But first, let me tell you about how to think about outcomes. This is called the Kirkpatrick Framework, and it's important that you be clear what level you think you're going to achieve with your improvement activities. So, first level, level 1, what's the experience? So I hope you're having fun. If you have fun, you go tell your friends, well, Goldmann was here, and he was kind of entertaining, and he jumped up and down and waved his arms. You had a good time. That's great. I've engaged you. That's level 1, and that's worth something. Level 2 means that you learned something. So if you can go off and give the elevator speech in 5 minutes and 54 seconds, I will know you learned something, and that's level 2, and that's good. But the question is then, will you go and change your behavior? Will you now provide better patient care? Will you have better teamwork? Will you round in a different way? If you do that, that's level 3, and that's important. Hopefully, those changes will be, and this is key, tightly linked to the outcome of interest. So I don't care if you change your behavior and it's got no relationship to the outcome for patients that you want to achieve. If you actually achieve those outcomes because the behaviors are linked to those outcomes, that's level 4, and that's, of course, the ultimate. And some of those outcomes may be delayed in time and hard to measure, frankly. So this is a way to display what I'm telling you about now. So first of all, we call, and this is jargon, that level 3 and 4 stuff the content theory. If, for example, I measure blood pressure looking for hypertension in young black men, because I know it's a problem in the United States for young black men. If I measure that blood pressure and I prescribe an appropriate medication, those are process measures. Those are things I do at level 3. I've changed my behavior because I really want to improve blood pressure control in young black men. Level 4 is if those same men go out and take the medication reliably, and actually I document that their blood pressure is lowered. Now, I can think of a lot of ways to mount this campaign so I can get to the content theory where I'm actually measuring, giving the drugs, and showing an outcome. Is that clear? That's the content theory. That's usually based on strong evidence. The process change of giving the drug is tightly linked to the outcome. There's a long-term outcome, lower stroke risk, lower heart attack risk in those black men, but I may not be able to measure that in my quality improvement process, but I know from evidence that that's what will happen. Then there's the implementation theory. What is my plan? What are my activities to get people to actually screen for blood pressure and then give the right medication? And there are various inputs. I have resources, I have staff, and so forth. I'm doing something that will engage people, and they're learning what to do so they can then go off and make the changes that will actually lower blood pressure in young black men. So if I want to go to a church and give out pamphlets on high blood pressure to the pastor so that he can preach about hypertensive control to his congregation, that's great. That's an activity and implementation plan, but I have to understand what is the output. Will the pastor actually give the sermon? Did anybody come to the sermon? Did anybody listen to the sermon? So it's all a theory. It's my implementation theory. It is not necessarily going to change behavior. So is that clear? Implementation theory, the implementation activities, inputs, resources, and getting to behavior change that I believe will result in a better outcome. So here's a little bit about a personal journey before we come back to that. Sometimes systems need major changes, not just tinkering. My son, when he was young, used to watch television a lot, and I would drive home and get into my driveway, and there's a pathway that's this crushed bluestone, and I could see into the window, my son in there watching the telly, I called it, and he would hear the crunching of my feet on the bluestone, and I would come in and I'd say, hey, are you watching the telly? And you know how effective that was, right? So that was a system psychiatrists who are interested in quality improvement called us a nightmare without end. And this went on and on and on for years. And finally I said, I need a fundamental change. I went in the front door, not the back door, went upstairs, washed up, changed, came down and said, son, how was your day? And he'll deny this, but it really did make a difference in his television watching, and he gave me permission to tell the story. And I would ask you, I'm not going to take the time to do it now, but if you go to YouTube and put in my name with 2 N's, and even better, Clapsies and cucumbers, you will find a video that shows PDSA testing from my garden on how to grow cucumbers. And you'll see that a relatively radical change finally led to the successful growing of cucumbers and a cucumber salad according to my aunt's old recipe. So I urge you to please look that up. It's actually, this is the only thing I'm famous for. People stop me at the pediatric meeting and said, you're the guy in the cucumber video. So please go watch it. If you watch the massive open online course from IHI and Harvard X, you'll see that I set a personal goal for aerobic exercise at the gym. 20 minutes on an elliptical at least level 10, which I'm told isn't much, at least 2 times a week. As a balancing measure, I want to be sure that I could still do my core strengthening stuff, because if I spend all my time and then I get sick of the gym and I don't do my weights, then that's an unintended consequence of what I thought was doing the right thing. You can display this kind of thinking on a driver diagram. These are clear. How many of you have done a driver diagram? Good, so I'd say about maybe a quarter. It's a clear, intuitive, visual demonstration of the most highly leveraged interventions that you believe will lead to the desired outcome. It's still a theory, it's still your prediction, it expresses your degree of belief in that prediction. You can easily hang measures, as I'll show you, on all of these drivers, and they make you very specific about what you're going to focus on. I always recommend an anti-driver diagram. What are the opposing forces that are going to get in the way of me driving my change to the outcomes I want? It's not ideal for showing complexity in interactions. It's very linear, as you'll see, and it ignores completely all of the quote-unquote less important factors that you couldn't get on the driver diagram, or more commonly, you didn't even know to measure. So it's not perfect, but it's certainly intuitive. Just be clear about the cause and effect, the content theory, the changes that you think will lead to the better outcomes, and be specific as to how much of a change you can expect. So here's a driver diagram, right? The cause and effect, and the aim is some sort of improvement, and there are usually just a couple to the most 5 primary drivers that are really important, that you really want to nail to get to your outcome. And then there's some secondary, less important drivers that help achieve those main changes, and then a bunch of specific changes you're going to test. That's it, very simply. So there's the new me, my elliptical. I'm going to get there. I'm not going to show you how far I've come, but as best as I know, there are only 2 drivers. Now, I'm a microbiome guy, and I think it's actually more complicated than this now. The microbiome is a kind of intermediary factor in my gut, but it's basically calories in and calories out. And I can limit my daily intake. I can substitute low-calorie foods. I can walk to my errands. I can fidget. You know, I was just in Charleston, South Carolina on a brief vacation. I eat like a pig. The food there is unbelievable. And I walk about 8 miles a day. I didn't gain a single pound. So that matters. But you notice I have alcohol on here. And alcohol, I told you it's hard to show complexity, but I do know that alcohol affects both calories in and calories out. There are how many calories in a glass of wine? Who drinks wine? Red wine, how many calories? Yes. Yeah, she doesn't know. So she's imbibing red wine, she doesn't know. But she's fit, that looks great. 180. Depends on how much alcohol in the wine, but about 180 calories. So if I go home at night after a stressful day and I have a couple of glasses of wine, that's 360 calories right there. Not only that, but if I come home after a stressful day and have my glass of wine, I do not go to the gym. So my calories out are also affected. And you can measure every one of these. I'm not going to go through this, but you'll see that every driver, every change can be measured. Because if you can't measure what you're doing to try and change, how do you know you're improving? I'll just leave it at that. And you can see what happens here. Here is what happened with my run chart on my elliptical that obviously it's been updated since then. But when I traveled, I found that I just can't keep up with this, and I've just given up on that. I just understand that if I travel, I've got to work doubly hard the next week. But that's my personal run chart. And you can do this on your own personal improvement project. In fact, if you're not doing a personal improvement project using these tools, then you'll never really learn them, is my prediction for you. So think of something you want to improve and start a run chart. Here's an MRSA controlled driver diagram, just to show you that this is applicable to clinical things. And there are only two primary drivers: prevention of spread of MRSA, let's say in your ICU, and prevention of infection with MRSA once you're colonized. So once you're colonized, then it's all about CLABSI bundles and VAP bundles and all that kind of stuff to prevent actual infection. But what you really want to do is prevent transmission. And you can have these slides. You can look and see what these changes are. But we have to be able to revise our prediction about what the important levers are all the time. So now we know that chlorhexidine washes in the ICU are really effective in controlling the spread of MRSA as well as other bacteria. So that would now go on your driver diagram, and you'd focus some effort on getting that done. So a couple of cautions: always understand the anti-drivers, always anticipate and monitor unintended consequences. Remember, if your goal for precautions for MRSA in your ICU is 100% compliance, there are several studies that show that patients on isolation are visited less frequently, have fewer vital signs and other kinds of important tests, feel stigmatized, get depressed, so all kinds of unintended consequences. And they're not a substitute for a logic model because they don't really show all of the implementation plan, the activities, the team training, the simulation that might be required to get to where you want to be. So I'm going to tell you a little bit about, I'm going to show you one logic model and ask you to look at it later if you're interested in this. But they do include the inputs and resources, all of your activities, their expected outputs, the outcomes, and they differentiate between the implementation and content theory. And here's one. Doesn't that look simple? This is what it involves. This was a national 10-state cluster randomized trial of staphylococcal detection and colonization for hip and knee arthroplasty that we did with federal money. This was not quality improvement without grants. Here we have the context. Across the bottom, we have all the assumptions, all the external factors, such as the Partnership for Patients that could have affected our work. We have all the resources, the grant money, the people that were going to be involved. We have all of the activities, the office hours, the webinars, all the things we were going to do to engage orthopedic clinicians and their teams across the country, what we expected to happen from all those, and then what the outcomes were going to be. And here you can see the aspirational aim was to reduce infections, but we didn't have enough statistical power to be confident we could show that. So the primary goal was actually, would people adopt the bundle of interventions to prevent hip and knee surgery due to staph that we were espousing, and that was our content theory. The rest of it was all the implementation plan. We thought and knew, based on evidence, that if people decolonized patients who were colonized with staphylococci, they would have fewer infections. Turns out that we have the results now, and not only did we increase adoption by a massive amount, something like 47% across the country, but surgical site infections fell significantly and substantially. So, but that logic model allowed us to understand what we were doing and allowed our evaluator to understand, even more importantly, what we were doing. So here's some examples of interprofessional work at the bedside with trainees. And I notice on the clock I don't have time to go through all of them, so I'll just tell you too. We're always hearing that it's really hard to engage trainees at the bedside because, first of all, faculty don't know how to teach quality improvement and they're very busy, so we get a month or we have a day where the residents go off or the fellows go off and they do their quality improvement. So I was a firm chief, as so-called, or a ward chief at Children's Hospital in the adolescent unit for over 10 years. And I was fortunate to have Don Berwick, the famous Don Berwick, as a faculty member and a nurse colleague who was the head of the ward, the adolescent unit, who at first thought I was going to be a typical doctor and she didn't want anything to do with me, and humiliated me at our first meeting, actually, with staff. And I went to her and I said, you just humiliated me with staff. I'm here to really work with you. And we became very fast friends. And we were routinely doing quality improvement stuff basically at the bedside. We have a lot of cystic fibrosis patients on the ward and a lot of patients with inflammatory bowel disease. And only 1 out of 10 could tell you who their doctor was, not by name, but they just couldn't say, yes, I know who my doctor is. So we began to script what the interns and residents would say when they went in the room. We scripted what the attending physicians would say when they went in the room, what I would say, and we began just to try to explain who the heck we all were and who their doctor really was. And within a matter of weeks, with some iterative testing, it was 90% said they knew who their doctor was. So simple on rounds. We got the pharmacy to show us a chart of which drugs were being most prescribed on our unit and what their cost was. And to our surprise, the #1 drug, it wasn't prescribed very oftenly, but in terms of cost, was ribavirin. And it turned out that people had this belief, this was a little while ago, that ribavirin was effective for RSV in severe cases or immunosuppressed patients. Well, the evidence is really weak, and it was costing $1 million a year for our unit to give ribavirin to those patients. It was fabulously expensive at that time. And within a day, we had made that policy that ribavirin could only be given with infectious disease approval, and it was never approved again. Tom Sandora, yes, Tom Sandora, I think some of you know, is Boston Children's Hospital. Those of you who come from Children's, was very skeptical about this whole thing, patient safety, adverse drug events. We don't see that at Boston. This is Boston Children's Hospital. So when I was on rounds with them, we simply kept a log of all of the errors we found in medications. Things like, oh, that dose for osteomyelitis for that patient going home is a quarter of what it should be, and that patient could easily relapse. We found so many errors, we published a paper in Pediatrics on medical errors found on rounding in infectious diseases. So this can be done in real time on the ward and make a difference. I'm going to tell you a story. People say, well, you know, we're serving the most underserved, our patients are so sick, we have staffing shortages, we have duty hours, and they go on moaning about these problems. The first thing I tell them is go to a high-end restaurant. I've studied restaurants. The higher end of the restaurant, the more people working in the kitchen, the more they communicate and get things done right. And have any of you ever worked in a restaurant? Yeah, well, that's a good thing to do, because you know that if you're in a high-end restaurant, you come in early in the morning and you prep everything, and then you have the orders coming in, and Tilly over there really, I know she said she liked her lamb medium rare. Now she says she likes it well done, and you got to redo the order. And then when it's all done, you got usually clean up and prep for the next day. It is hard work. Totally team-based, totally based on communication, totally based on systems. As one of the chefs at a restaurant in Waltham, Massachusetts, said when I was sitting at the counter, he was the guy that put the chickens on the rotisserie, and they're known for their rotisserie. And every time he took a chicken, put it on the rotisserie, went to the sink, lavishly scrubbed his hands, and used a dry paper towel to dry them, and the place is in chaos, right? The patrons are pouring in. I asked him, I said, how do you remember to do that? And he said, because that's our system. I know if I don't do it, we could have a outbreak of diarrhea in our restaurant and we'd be closed and I'd be out of a job. Very, very simple. We don't have that same attitude. So Bogota, during the Medellin drug cartel crisis, I was picked up by, Mary picked me up today. She would have been in an armored car because her brother was kidnapped for ransom. That's the environment we were in. And it was winter and raining constantly in Bogota. The roof leaked in my room. I couldn't get to the shower without taking a shower from the leak. Horrible conditions. with a small grant, I think it was total $45,000 to get us there and get us this leaky roof hotel. We worked with two safety net, is basically what I call them. They serve the people in the barrio, to reduce their cesarean wound infection rate, which was sky high. And I won't show you the gruesome pictures, but they had a problem. First thing they did was, well, what's our causal theory? What is our content theory? What do we think causes endometritis and cesarean wound infection? And we had them put sticky notes up and all that kind of stuff. This was their causal theory, and it came down to 5 buckets: perioperative antibiotic prophylaxis, skin prep, surgical technique, post and antenatal factors, and then peripartum events. And you could study this, you'll see all the things that you might have predicted would cause infection. And that was essentially their cause and effect driver diagram, which in a way is just another display of a driver diagram. It's the causal theory. Is that clear? It's like similar to a driver diagram. That's their theory. And they were especially interested in the antibiotics. You always have to have the evidence. They said, well, how do we know these antibiotics work? We're in Bogota. What do we know about this? I had in my pocket all the meta-analyses that had been done up to that time on prophylaxis for cesarean delivery. And here you can see the results. Remember, anything under 1 that has those bars that don't intersect 1 is statistically significant. Look at the size of the effect. This isn't subtle. Antibiotics really do prevent infection. So, wow. Then they had to prioritize, well, what are we going to work on first? So across the vertical part of this table, you see the 5 buckets in their content theory: antibiotic prophylaxis, skin prep, and so on. And they did a priority matrix, which is good for your own life. If you want to set priorities for a vacation, your next job, raising your children, do a priority matrix. Very few people use this simple tool. I use it all the time, as I'll show you. The impact, what's its likely effect on the outcome? Is it within our span of control to actually do this? How easy it will be to implement? What will it cost, and how long will it take? Those were the things they thought were important. The higher the number, the more likely it was to meet these criteria. Well, antenatal factors are important, but those people are living outside the span of control of those medical centers, and that's a common problem we have. We're trying to get beyond that in medicine, but right now, it's not really in our span of control. Antibiotic prophylaxis was something they thought they could do that would have a major impact. It would be relatively easy. They didn't think it would be very costly, and they could do it very, very quickly. By the way, here's my priority matrix. Last year, I planted 4 types of kale: dinosaur kale, otherwise known as Tuscan, dwarf blue, red Russian, and meadow lark. And those are my criteria: flavor, whether they're heirloom, pest resistance, heat resistance, very, very important. Once it gets hot, it tends to bolt. And you can see meadowlark kale really didn't do very well on heat tolerance. It took a long time to harvest, and it scored the lowest of all the kale. It's not in my garden this year. So, otherwise I'd just be kind of doing it by hunch. So here's what we found. They didn't have a big database, so we pulled something like 25 or 30 charts that were hanging around. In Hospital A, 70%, only 70%, but better than the other hospital, got antibiotic prophylaxis. The timing of the prophylaxis was wrong most of the time in the hospital that gave the drugs. Not that great in Hospital B, but a little bit better. Not good. They looked at this and said, we do not need a researcher. We don't need to hire a medical student or a nurse to collect these simple data. Then they had to map the system. This was the old system, and I know we have to finish very soon, so I'm aware of that. This will be my last story, I promise. They had to plan to perform the cesarean delivery. The doctor had to then write a prescription, and then that prescription went to the pharmacy. The pharmacy had to stock 7 or 8 different antibiotics because every surgeon had their own preference. One of them had some drug that was donated by, I think it was Eli Lilly, that cost a fortune and wouldn't be available once the grant was over. But the pharmacy often didn't have the drug that the doctor wanted in stock because it's a poor hospital, safety net hospital. If they didn't have it, they had to then tell the doctor, write another prescription. The patient would take it out to a van in a courtyard, the family to a van in the courtyard, get the drug, bring it back in, run the labor and delivery in the hope that if they had the money, that the drug could be administered. Terrible, terrible system. Here's the new system. After they did a lot of work using kind of systems orientation. Doctor writes a prescription. The default is give the drug. If you don't want to give the drug, write a reason why. There are only 2 drugs, cefazolin and clindamycin for allergy. They're both cheap. It goes in the packet with the mother. the mother goes to the OR, the drug is administered. This is a time series analysis. I'm not going to spend much time on it, but basically it's very simple. Here you see the giving the drug improved very quickly. It still was some issues with timing as they got the systems in place. But over time, there was more than a twofold reduction in surgical site infection, and the paper got published. So here you have a fellow, an obstetrician, myself, a nurse, working as a team on a very small grant just to get us there, doing quality improvement training just in time, the 7-minute drill, and got a really good result and a paper out of it. So I'm going to stop there because time's out. If you want to read about this some more, you can look up well, I don't have the reference here, but we've learned how to do what's called random safety audits, which are done as part of routine work. You just pull a card out of a deck about what you're going to monitor on rounds that day, and in the neonatal ICU, by consensus, there were something like 14 patient safety issues that they wanted to monitor every day. You randomly picked one. On rounds, you had a checklist. Did it happen? Didn't it happen? And on the first day we did this, we found that the O2 SAT monitors were set incorrectly. They were set too high in the neonatal ICU. Premature retinopathy of the newborn was whatever it's, I can't remember, whatever it's called, retinopathy of newborn was a real risk factor, and that day we were able to correct that. And the next day we did hand hygiene. So you can do this as part of routine work. If somebody says to you, I need to hire a nurse, first of all, nurses are our most important member of the team, in my view, especially in neonatal care, where they're the only people that seem to touch the patient. Doctors almost never do. If we want to take a highly trained nurse to collect data for some project, we should ask ourselves, why doesn't our system of work allow us to collect the data we need for quality improvement in real time at the point of care, so that at the end of each day or each week, we can look at what we just did and say, wow, we have an opportunity here for improvement, and now we can monitor whether or not we do it. So never succumb to the temptation just to hire somebody to collect your data, not for quality improvement. So thank you. I'll stop there. I'm sorry I ran a little over.